Cindy Choi was a student when I got to know her a few years back, not a long time ago. She's been a very good MSc student and has recently graduated. Meanwhile, she's been research assistant and research administrator and all these uh, all these titles engaged in research with St. Paul's Hospital and what is it called? Advancing Health. Email address that they have. It used to be called Chaos, for those of you who remember CHEOS, but Chaos was not a good word anymore. And we now have Advancing Health. So the floor is yours, Cindy. Please go ahead. And if I'll watch the chats, and I'm sure Madeline, you are doing that too. So if there's any questions that I can address or pick up at for the end of the presentation, it will be a 40-minute presentation and then time for questions. I know presentation will be very interesting and animated. So go ahead.
Thank you, Dr. Kazenjan, for the introduction. Let me just share my screen. Are you able to see the first screen?
Yeah.
The full size? Perfect. Hi, everyone. So my name is Cindy. So today I'll be talking about a couple of study findings from my thesis project. So lessons from the pandemic, access to treatment for anxiety and depression, and potential implications for cancer survivors. Before we begin, I would like to acknowledge that I'm currently located on UBC's Vancouver Point Grey campus that is situated on the traditional, ancestral, and unceded territories of the Musqueam people. So anxiety and depression are considered one of the most common mental disorders, with 1 in 3 adults experiencing anxiety and 1 in 6 adults experiencing depression in their lifetime. And COVID-19 was a global crisis as well as a public health emergency. Globally, 14.9 million excess deaths are associated with COVID-19 in 2020 and 2021, with WHO announcing COVID-19 as a global pandemic on March 11th, 2020, followed by BC announcing provincial state of emergency on March 18th, 2020. Now, a wealth of studies suggest that COVID-19 intensified existing mental health needs, leading to higher levels of anxiety and depression without adequate support. This is a global prevalence and burden of depressive and anxiety disorder study across 204 countries and territories in 2020 due to COVID-19. So on the left side, COVID-19 pandemic was associated with 25% increase in prevalence of anxiety and depression worldwide, and younger people were hardest hit. And these increases were higher among females than males. Sex and gender are considered one of the core determinants of health, and sex and gender disparities in mental health are fairly well documented. Women are twice as likely to be diagnosed with anxiety or depression than men in lifetime, and numerous studies report higher levels of anxiety and depression levels during COVID-19 pandemic, disproportionately affecting women. As such, it is important to adopt a sex and gender specific approach in how men and women differ in receiving care related to mental health issues to bridge this gap. Mental health needs of Canadians were chronically unmet prior to COVID-19, where 80% of Canadians rely on their family physicians for their mental health care needs. However, 1 in 5 Canadians reported not having a family doctor they see regularly. In 2018, 43% of Canadians reported that their mental health needs were either partially or fully unmet, highlighting the significant gaps in mental health care. These gaps in care extend beyond just the general population. Cancer survivors and individuals with chronic illnesses are at heightened risk for psychological distress, and they face even greater barriers to mental health support. So anxiety and depression rates in cancer survivors are at least double that of general population estimates, with about 14 to 24% of survivors experiencing clinical levels of depression and around 10% reporting clinical levels of anxiety. General population estimates are around 5% for depression and 7% for anxiety. Mental health services remain underutilized in this population, with fewer than 10% of cancer survivors reporting having access to mental health specialists. By examining access to mental health care before and during the pandemic, we can examine the structural and behavioral barriers that may also impact cancer survivors seeking psychological support. This is a population-based study that looked at sex disparities in anxiety and depression levels and access to care in the adult population, comparing trends before and during COVID-19. In this session, we aim to first examine how COVID-19 pandemic impacted changes in the trend and level of anxiety and depression in men and women. Second, to explore how the pandemic affected the rate and type of treatment received for anxiety and depression among men and women. And finally, to discuss how shifts in mental health care access during COVID-19 can inform future strategies to support cancer survivors. Before we head into methods, it's important to note that in this study, we are considering sex as a proxy for gender, and sex and gender are closely linked but distinct constructs, where sex refers to the biological characteristics associated with physical traits of a person, usually categorized as male or female, whereas gender refers to an individual's personal and social identity as a man, woman, or non-binary person, and can change over time. They are closely linked, as in 2021 Canadian census reported that majority of Canadians aged 15 and older identify as cisgender, where their gender identity corresponds with the sex assigned to them at birth. Because we're using health administrative data sets where sex is available variable, as males or females, and the interrelation between sex and gender, we will interpret our study findings in the broader context of societal impacts and gender inequities that influence mental health outcomes. So the following health administrative data sets from BC Ministry of Health were obtained through Population Data BC. And Population Data BC provides researchers with services supporting access to collection of population health data through data partners, which includes BC Ministry of Health. We have used Medical Services Plan. This is the physician billing data that captures data on medically necessary services provided by fee-for-service practitioners to people covered by Medical Services Plan, and this is a BC public insurance plan. We linked this with National Ambulatory Care Reporting System, or NECRS data that captures the ambulatory data and emergency department visit data, and also the central demographics file. This is from a medical services plan registration file that captures the basic demographics of BC residents, including sex, birth, year, month, and BC resident status. So study period, because we're looking at pre-pandemic and pandemic level and trend changes, we define onset of COVID-19 as April 2020, pre-pandemic period as April 2018 to March 2020, and pandemic period as April 2020 to March 2022. So 2 years before and after the onset of COVID-19. Individuals who met the following eligibility criteria were included in the analysis. So first, we were looking at BC residents 18 and older, and then looked at those with active registration with Medical Services Plan for at least 6 months within each year of look-back period, and then extracted monthly treated incident cases of anxiety and depression, then looked at 1-year treatment follow-up. So diagnosis was considered an incident case for the study if there was no identical diagnosis in the preceding 2 years, which is anxiety or depression. First objective of the study is to look at the impact of COVID on the changes in the trend and level of treated incidence rates for anxiety and depression between men and women. From the incident cases of anxiety and depression, we then further stratified by sex and age groups and ran controlled interrupted time series analysis. And this analysis allows for both within group comparisons, so comparison of pre-pandemic and pandemic trends within each sex, and between group comparisons, so comparison of level and trend changes between males and females by looking at the baseline trend in the intervention group defined as females, and then control group in males. It will make better sense if we look at the graph. So this is the treated incidence rates of anxiety across all age groups. Right in the middle is the onset of COVID at April 2020. When we're looking at pre-pandemic baseline levels in April 2018, in red are females and in blue are males. And we can see that females have about double the rate of incidence rate compared to males at around 8 per 10,000, and for males around 4 per 10,000. At the onset of COVID, we see a significant increase in the incidence levels of anxiety for both males and females, but at a greater magnitude for females. And this trend to decline over time back to pre-pandemic levels. For depression, we see similar baseline trend in that females have higher incidence of depression at 8.6 per 10,000, and for males at 4.6 per 10,000. At the onset of COVID, there is a marginal increase in depression levels for females and actually a slight decrease in males, but this was not significant. And there were no trend changes during the pandemic. So to summarize, our results suggest that prior to the pandemic, females reported up to twice as high treated incidence rates for both anxiety and depression, and higher incidence rates were observed with younger age groups and decreasing with age. At the onset of COVID-19, anxiety levels have increased for both men and women, with greater increase among women across all age groups. And for depression, males in younger age groups, so 18 to 44, reported decrease in depression levels, whereas females reported age 65 and over reported a significant increase. And these findings align with existing research showing that women not only experience higher rates of anxiety and depression than men, but also disproportionately affected by the pandemic. Additionally, despite the initial increase in anxiety and depression levels, the trend of treated incidence rates for anxiety and depression decline over time, returning to pre-pandemic levels. And this decline could either suggest that the mental health impacts of COVID was short-lived, or that there were barriers to care, preventing individuals from seeking diagnosis and subsequent treatment. So this brings us to part 2 of our study, which looked at changes in treatment access for anxiety and depression before and during the pandemic. So individuals with incident cases of anxiety or depression were followed then for 1 year since diagnosis to assess the follow-up care. We looked at 4 outcome variables. So following their primary diagnosis of anxiety or depression, whether they received at least 1 counseling sessions provided by their GP or specialist other than psychiatrist, and 2, at least 1 psychiatric service or treatment rendered by a psychiatrist, and then at least 1 emergency department visits, and then at least 1 physician visit other than for counseling, psychiatric treatment, or emergency department visits. So for doctor's visits, this is most likely a follow-up visit with your family doctor. We then adjusted for age, income quintile, health service delivery area, and ran a log binomial regression analysis. So this analysis was performed to explore sex differences in the likelihood of receiving follow-up treatment for anxiety or depression before and during the COVID-19 pandemic. And this analysis estimates the relative association of predictor variables, so sex and period, on binary outcomes, so whether they received treatment through risk ratios. The risk ratio allows us to directly compare the probability of the outcome in females to the probability of the outcome in males. So this is a side-by-side comparison for anxiety and depression, first looking at counseling. So looking at the proportion or percentage of females and males that received one or more counseling sessions within a year of being newly diagnosed with anxiety or depression. So how to interpret this graph is for anxiety, for example, in orange are females and in blue are males. For pre-pandemic, 16% of females that were diagnosed with anxiety during the pre-pandemic were receiving one or more counseling sessions within a year since diagnosis. And for males, this is 13.8% of males who were diagnosed with anxiety before the pandemic receiving one or more counseling sessions that year. So for both anxiety and depression, women are more likely to receive counseling sessions than males. And during the pandemic period, both men and women were less likely to receive one or more counseling sessions compared to pre-pandemic periods. Second is psychiatric treatment. For anxiety, there were minimal sex differences in the receipt of psychiatric treatment across pre-pandemic and pandemic periods, with about 5 to 6% of males and females diagnosed with anxiety receiving one or more psychiatric services. For depression, men were more likely to receive psychiatric treatment during both pre and pandemic periods compared to women. And during the pandemic period, women were less likely to receive psychiatric treatment. For emergency department visits, for both anxiety and depression, men were more likely to have one or more emergency department visits than women. Both groups were less likely also to have emergency departments during the pandemic. And this was fairly comparable between anxiety and depression. Lastly, for doctor's visits, over half of men and women who are diagnosed with anxiety and depression do have a follow-up visit with their doctors. And this is the one that shows an opposite trend. So women are more likely to have doctor's visits than males during pre and pandemic periods for anxiety and depression. And both men and women were actually more likely to receive doctor's visit during the pandemic compared to the pre-pandemic levels. And this may be family physicians often provide pharmacotherapy, referral to specialist care, for example, psychiatric treatment, and provide limited number of counseling. The reason we see a decrease in counseling but an increase with doctor's visit may mean that they are seeking follow-up visits for pharmacotherapy treatment. However, we did not look at the PharmaNet data in the study, so that is a speculation. On the flip side of things, this table shows the proportion of individuals who did not receive any follow-up treatment within a year since diagnosis. And for anxiety, about 1 in 4 individuals didn't receive any follow-up treatment within the first year of diagnosis. And around 13 to 15% of people with depression didn't receive any treatment. To summarize, our results indicate that there were significant sex differences in the use of mental health services before the pandemic, where women were more likely to receive counseling and doctor's visits, while men were more likely to visit emergency department within first year since diagnosis for anxiety and depression. Men with depression diagnosis were more likely to receive psychiatric treatment, whereas marginal differences were found for those with anxiety. During the first year of the COVID-19 pandemic, there were also measurable changes in the receipt of treatment for both anxiety and depression. And both men and women diagnosed with anxiety or depression were significantly less likely to receive counseling, have emergency department visits, and marginal decrease in psychiatric treatment. In contrast, both groups were significantly more likely to have doctor's visits. Interestingly, impact of COVID-19 on the use of mental health services didn't differ significantly between men and women, perhaps signifying a systematic or structural barriers that affects both groups. This leads us to discussion. And the observed sex differences in anxiety and depression levels, as well as treatment access, may be explained by the interplay between the individual and environment at different levels. And socio-ecological model of health posits that individuals' health and well-being are affected by the complex interactions between the individual, interpersonal relationships, community factors, public policy, and society. And this model will be used to guide the discussion for this study. So at the individual level, there are animal studies that found greater susceptibility to stress and higher inflammatory response in females. Also, studies report that women experience higher levels of chronic stressors and view them as greater threat than men. Sex hormones, for example, progesterone and estrogen, were associated with increased vulnerability and anxiety. Also, 21 to 35-year-olds, so younger age groups, are the median age of onset for anxiety and depressive disorders. So these physiological sex differences may explain why we saw a higher baseline anxiety and depression levels in females compared to males before the pandemic. There's also the tend and befriend theory to threat and not fight or flight. And this theory suggests that women are more likely to respond to stressful situations by nurturing those around them and seeking social support to foster connection. Studies show that women are more likely to seek emotional support, engage in positive self-talk compared to men when faced with stressors, whereas men are more likely to engage in avoidant coping strategies. And this may perhaps explain why women were more likely to seek relational forms of coping, such as counseling. So during COVID-19, there were provincial restrictions that were imposed to curb the spread of the disease, including ban on non-essential travel, closure of non-essential services, for example, restaurants, movie theaters, indoor group activities. There were limits on social gathering, and there were social distancing measures, for example, staying 2 meters apart, which has contributed to increased social isolation. There were also school closures, which added caregiving responsibilities on parents in single-parent families. And greater stressors were more put on women that provide more caregiving responsibilities and domestic care for children and also elderly. So these provincial-wide restrictions put further strains on interpersonal relationships and families, especially women. Additionally, at early pandemic, healthcare resources were redirected to manage COVID-19 patients, which led to delays in non-essential physician services. And COVID-19 related delays in access to care were linked with worse perceived mental health. So a study found that during the first year of the pandemic, about 30% of Canadians report having delays in seeking medical care, with 9% not being able to receive mental health or addiction services such as counseling or therapy. And also there were shifts to virtual delivery of care, which was a great alternative to reduce the face-to-face interactions. However, this also added navigational challenges who do not perhaps have the technical literacy or the resources or are unfamiliar with the healthcare systems. Before the pandemic, not knowing where to go for help and experiencing long wait times were commonly reported barriers to care. And so the pandemic-induced delays in the transition to telehealth likely worsened these navigational challenges, particularly for men. And so heavy burden of COVID-19 on the healthcare systems likely affected both men and women to be less likely to receive counseling, emergency department visits, and also psychiatric treatment. At the societal level, women are socialized to show more emotional and seek support for emotional distress, whereas masculine norms promote self-reliance and stoicism. There are also traditional gender roles where women take on greater domestic responsibilities, and this still is true in Canada. So social norms and gender roles do affect help-seeking behavior, which may have been exacerbated by COVID-19. Men experience more stigma associated with seeking help for mental distress, and men tend to be more reluctant to disclose emotional distress, tend to minimize mental health symptoms. Studies found greater adherence to traditional masculine norms were associated with reduced help-seeking behavior among men and poor mental health literacy in men were associated with lower mental health service use. And the compounded effects of stigma and low mental health literacy may explain why men are less likely than women to seek doctor's visits for anxiety and depression and are less likely to engage in counseling. And this may lead to potential pattern of delayed help seeking until their symptoms worsen, explaining why men were more likely to have emergency department visits for acute care for both anxiety, depression, and also psychiatric treatment for depression. Please note that in the study, we did not look at symptom severity. However, the fact that they're seeking acute type of care and getting a referral from a family physician to see a psychiatrist could be indicative of severity of symptoms. There were COVID-related economic downturn, and on average, women do earn less than men, and gender pay gap has persisted over COVID-19 pandemic. Women are also overrepresented in retail and service industries, as well as in healthcare industries. And there were significant burden on healthcare workers, where healthcare workers were met with increased workload, higher risk of exposure and infection, dealing with burnout, trauma, and grief during COVID-19. Women also represent 75% of all care workers in Canada, and this may implicate why women had higher anxiety levels compared to men at the onset of COVID-19. So key takeaways, our findings suggest significant gaps in treatment, access for anxiety and depression exacerbated by additional individual, interpersonal, and economic burden impacted by COVID-19. Women were disproportionately affected during COVID with higher increases in treated incidence rates of anxiety and depression compared to men. During COVID-19, men and women with anxiety or depression diagnosis were less likely to receive counseling, psychiatric treatment, and emergency department visits, whereas they were more likely to have a doctor's visit. And these findings underscore a need to explore sex and gender-specific barriers and access to care to bridge this gap in disparity. Additionally, we saw that 13 to 15% of individuals with depression and 25% diagnosed with anxiety didn't receive any follow-up care from their primary care providers within a year since diagnosis. And this highlights the need for better connections to primary care for timely support. And please note that this is public funded care under MSP, and this does not capture out-of-pocket services. So a few policy implications from this study. We would need timely resource allocation for mental health during early stage of crisis because we did see an increase in anxiety and depression levels, especially for women, but we see a less uptake in counseling and psychiatric treatment. We would need enhanced mental health resources for subpopulation disproportionately affected by the pandemic. For example, healthcare workers, caregivers, those experiencing job loss or unable to work due to family care responsibilities. We would need additional resources to support greater access to counseling and psychiatric treatment. Clinically, both pharmacotherapy and counseling have similar efficacy in terms of treatment, but we saw a decrease in counseling and psychiatric treatment. Additionally, we would need policies that would reduce stigma and promote psychoeducation for recognizing and treating symptoms of anxiety and depression. This is especially true for men that tends to underreport their symptoms. So this study was among the first few population-based study to examine the impact of COVID-19 on incident cases of anxiety and depression and follow-up treatment in Canada. Using health administrative data sets, we do have generalizability of findings capturing the representative sample of BC populations. The study is not without its limitations. As we discussed, the study does not directly capture gender, so experiences of gender diverse individuals. And also the study doesn't capture individuals seeking private out-of-pocket mental health services. And so it is most likely that access to mental health treatment is a very conservative estimate. So how do our findings relate to cancer survivors? We explored trends and common barriers to care in the general population, and cancer survivors face additional unique barriers related to their diagnosis, treatment experience, and long-term survivorship needs. So this is from my general environmental scan in preparation for this webinar. And I found that most cancer survivors transition to community or primary care after treatment, while some receive a needs assessment and follow-up surveillance plan. Mental health support of where to go for help and what kind of services are available is not always included. Survivors treated at large cancer centers may access integrative programs, but referrals to specialized psychosocial care are limited, and many who could benefit from psychosocial interventions are either not identified or supported immediately after treatment. Mental health challenges are pervasive in cancer survivors, with 8 in 10 cancer survivors, and this is a report from Canadian Partnership Against Cancer in 2018, 8 in 10 cancer survivors reporting at least one emotional challenge post-treatment, with anxiety, stress, and fear of cancer recurrence being the most common. And 15 to 40% of survivors having high psychosocial needs, including fear of recurrence, anxiety, depression, and PTSD. Mental health conditions in cancer survivors are linked to reduced quality of life and higher mortality risk. And despite the importance of mental health supports, there are significant barriers, with over 50% of cancer survivors not seeking help from a healthcare provider for an emotional concern. And common reasons for not help seeking were identified as they were told their emotional concern was normal to expect and didn't think anything else could be done. They didn't want to ask, was embarrassed, didn't know where to go, didn't think that there were services available to help me. And not knowing where to go for help is already identified as a common barrier in the general population as well. During COVID-19, cancer survivors have also reported greater emotional distress and psychosocial needs. During COVID, there was a study that identified psychosocial needs among cancer survivors as key to mental well-being and quality of life, which included need to feel safe in relation to risk of contracting COVID-19 and ongoing cancer monitoring. And this is especially true in the face of healthcare delays during COVID, and also needing to feel connected to people, places, activities in everyday life, and the need to make the most out of life after cancer treatment. Our study identified sex differences in access to mental health care services and explored common barriers to care in the general population. And while existing research highlights the high prevalence of emotional distress among cancer survivors, I found that there were actually few studies that looked at sex and gender differences in access to mental health care. So addressing these disparities require a deeper understanding of how sex and gender may intersect with broader environmental, structural, and systematic barriers to care in cancer survivors. So as a future direction, there's a need to explore sex and gender differences in mental health support in cancer survivors by examining how pre-existing sex differences in anxiety and depression may impact help-seeking behaviors and access to mental health care, and to promote gender-sensitive and personalized mental health care access to care by developing tailored interventions that address the unique emotional and psychological needs of cancer survivors post-treatment. And finally, to examine the long-term effects of public health emergencies such as COVID-19 on mental health care access. See. And that concludes the end of my presentation. Thank you for listening. I would like to quickly acknowledge my supervising committee for my thesis, which was Dr. Joseph Puyat, Dr. Daniel Bigo, and Dr. Armini Kazanjan. I'm happy to open up the floor for any questions and discussions.